Thank you, Jonathan. And thank you for the invitation to speak today. So I'm going to discuss the considerations for pharmacists when implementing long-acting injectables in the community setting. So before addressing the question of how to do it, it's important that we think about what we're aiming to do. We need to consider how, although long-acting injectables can improve adherence to therapy, can address some of the barriers of adherence to oral regimens, we could also improve access by addressing barriers to accessing injectable therapy in order to improve equity of access. So things like travel to clinic, socioeconomic barriers to that, stigma associated with attending clinic in the traditional HIV clinic setting, and mobility issues, as well as a number of other factors. But it's very important that we consider patient choice here and flexibility, and that we are able to adapt to make such a service implementation successful. It's also vital that we consider the evidence base when we consider how to inform any changes that we implement. So the Alana study was an implementation science study that was conducted in the UK. It followed a diverse group of participants who were 54% female, 70% from racially minoritized backgrounds, and 40% of these were aged over 50. Injections were initiated in the HIV clinic, and participants were given the opportunity to have continuation injections in a community-based setting. The majority of these were community-based hubs, and for a small number, the site of injection was at home. I think it was 3 people in total. Only 24% of all participants chose community settings for continuation of injections. However, those that did choose it found it highly acceptable. For those who chose not to continue injections in community, the main barriers to accessing community injections were loss of access to their trusted clinicians, stigma, and confidentiality concerns. The Invite Home study was a US-based study that was carried out in San Francisco, and this was quite different in approach. It explored long-acting injectables being delivered by a layperson injector in the participant's own home. It was found that the benefits for this for the participants were convenience, privacy, and empowerment, and for the clinics, the main advantage was reduced pressure on clinic resources. They also found some challenges, such as maintenance of the cold chain, delivering of training, digital record sharing, and use of recall systems. So, given the observed outcomes of these studies, it's really important that we think about how we're improving quality of life when we implement such services, and also how we're making the best use of resources. When considering the best use of resources and convenience to the service user, it's important that we think about how we might be able to integrate services. So, for example, administering injections in primary care or community pharmacies, which would offer a kind of convenient local solution to people to reduce travel need and make sure that care is local to home. It might also be beneficial for those who feel stigma associated with attending an HIV specialist clinic as well. We could also consider integrating with services such as drug and alcohol centres, hostels, care homes, mental health services, in order to improve efficiency of both services and also access to care for those who may struggle with attendance and engagement with care as well. So this might also improve equity of access beyond the HIV clinic setting. When considering the practicalities of how we might implement such services, it really is dependent on the local setup and infrastructure of the healthcare system. However, there are some principles that apply to all settings. So there needs to be a robust referral and assessment system in place. It's important that the entire multidisciplinary team are involved in identifying people who are suitable to receive injectable therapy, as well as those who may benefit from injectables within the community. And it's really important as well that the individuals are involved in shared decision-making here, as we shouldn't make assumptions about who and who might not benefit from injectables and community administration. It's also important that there's access to the appropriately trained healthcare professionals, so we need to maintain access to specialist pharmacists, specialist nurses, and specialist physicians as well. There are also drug storage and transport considerations as well. The practicalities of administration will depend on the chosen model of community delivery, and the existing MDT who are already trained may be able to deliver the service in an outreach setting, and Katerina's spoken a little bit about that kind of model of care, but it may also be possible to train other specialists or community-based colleagues in the administration of injectables and the care that surrounds it. It's also important from a safety point of view that there's access to anaphylaxis kits, particularly for administration of the first dose, that the recipient's observed for 10 to 15 minutes post-injection, and that there's the facility to do this. There's also practical considerations such as how monitoring will take place, access to pathology labs, documentation, electronic patient records, and also referral pathways if there are any complexities arising from care or any safeguarding issues. Where there are multiple teams and multiple members of the multidisciplinary team involved, it's important that responsibilities and roles are clearly defined. So pharmacists and pharmacy teams, as well as being involved in cold chain maintenance and supply logistics, should also ensure that there's regular review of co-medications and comorbidities, provide advice accordingly, make sure that they're liaising with the appropriate healthcare professionals if there are any complexities that arise, and also consider documentation and how we might support with digital integration. For nurses and consultants, it's obviously important to make sure that there's a seamless care pathway, that there's oversight, there's a pathway for advice and escalation if needed. We all know that cabotegravir is stored at room temperature. However, rilpivirine needs refrigeration. That should say between 2 and 8 degrees, not between 2 and 6 degrees. And that's required at all times. Once rilpivirine is removed from the fridge, it's stable for up to 6 hours and it cannot be returned to refrigeration, so it must be used, otherwise it will be wasted. So this is an important consideration, particularly in outreach settings, but there's also the supply chain to community-based clinics to consider, depending on how supply and acquisition of antiretrovirals works. In the area that you work. In the UK, it's quite complex because only specialist centres can procure antiretrovirals. It may be similar elsewhere. So it's important that there's an insulated storage box and that you have temperature monitoring with a probe, and that this is recorded regularly as well to ensure the integrity of the drug that we're administering. And I've touched on this already, but the other really important consideration is the digital systems. So not just for recording the dose administration, but also recall systems, follow-up for missed or late injections, abnormal results, safeguarding issues, and there's a lot of complexity to consider when different organizations are sharing data. So there needs to be robust information governance, training, and pathways in process. And we also need to consider how we can deliver training on that so that every centre involved in shared care can demonstrate that they are supporting this in the correct way. So in summary, in order to ensure safe and effective implementation of community-based injectable delivery, it's essential to maintain the cold chain. Injectors must be suitably trained and able to deal with complications of administration. Clear and accessible documentation is key, and communication between settings and MDT members is essential. All service developments should keep the individual at the centre of the services offered to ensure that their unmet needs are best supported. There are opportunities to expand delivery to numerous settings beyond the clinic. However, access to the specialist team should be maintained, and efficiencies can also be achieved with continued collaboration and regular service evaluation. I will end there. Thank you.